Dear colleagues in the Top End Health Service, welcome to this modified BLS and ALS education video. During the COVID pandemic, the Top End Health Service strives to continue good patient care as well as ensure staff safety for all of our healthcare professionals and other staff members. If during the COVID pandemic a patient who is suspected or confirmed to have the coronavirus infection suffers from a cardiac arrest, we want to provide good basic and advanced life support, but also ensure sufficient protection for our staff members who will provide the life-saving support. The Top End Health Service has created a modified BLS and ALS guideline that is available on the PGC. We have created this educational video where we'll show you a cardiac arrest scenario in the primary healthcare setting with those modified basic and advanced life support guidelines. Minimal changes to the standard ARC, BLS and ALS guidelines have occurred. The minimal changes relate to wearing the appropriate PPE, minimizing staff exposure by minimizing the number of people in close contact to the patient, and reducing the risk of droplet and airborne contamination in regards to airway management. This educational video will show you how these principles can be applied in the primary healthcare setting. We are here in Belyuen. I'm sitting on the virus tree where patients who have suspected to have the COVID infection will wait until the healthcare professional has done the appropriate PPE and will attend their care. We will continue this video by reviewing the modified BLS flowchart. First of all, we follow doctors A, B, C, D as per the usual guideline. So we check for danger, and during the COVID pandemic, this means we have to ensure that we are wearing the appropriate PPE before we attend the patient's immediate environment. We then check for response as we would usually do. We speak the patient's names loudly and gently shake their shoulder. If the patient is unresponsive, we will call for help. In the primary healthcare setting, this would mean we get a helper from the environment, for example, a colleague or a driver, and call the DMO on call via switchboard and ask for us to be transferred urgently. We also ask our helper to get the resource trolley and then don their PPE. We then move on to the airway. We open the airway, place a non-rebreather oxygen mask on the patient's face, turn the oxygen onto 15 liters and cover the face with a plastic sheet or a bluey or a piece of clothing. This to prevent any droplet or airborne contamination while we're providing the life-saving care. We then move on to breathing. So we check for breathing by looking to chest rise and fall only. We do not listen and feel with our mouth and ear close to the patient's mouth. We also avoid doing back mask ventilation. This again to prevent contamination with droplets. When we have confirmed cardiac arrest, if the patient is still unresponsive and has absent normal breathing, we will start compression-only CPR. This means we will continue CPR at 100 to 120 times per minute and continue doing that until our defibrillator arrives. When a helper has arrived with the defibrillator and has done the PPE, our helper will continue doing the compression-only CPR at 100 to 120 times per minute, and the healthcare worker will attach the beds, will turn off the oxygen at the bottle and follow the prompts from the AED to see if a shock is delivered while maintaining safety for the staff member surrounding the patient's bed space. We now move on to our modified ALS algorithm. If we have our DMO on speakerphone, the DMO might advise us to administer drugs such as adrenaline or amiodarone according to the ALS algorithm. The DMO might also request us to secure the airway by putting in an LMA. During this time, we continue doing CPR according to the shockable or non-shockable algorithm as per the guideline in 2-minute cycles as advised by the AED. If the DMO requests to put in an LMA, we avoid doing back mask ventilation. We put in the LMA. When the LMA is in successfully, we attach a viral filter and attach the bag. We gently squeeze the bag and observe if there is any significant leak. If there is no significant leak observed, we can now say our airway is secure. We continue our CPR by continuing chest compressions at 100 to 120 times per minute and continue providing bag ventilation at 10 times per minute. The DMO can advise us on further steps in the algorithm until help from the retrieval team has arrived or until the patient has returned of spontaneous circulation. We now continue looking at these principles from the basic and advanced life support modified COVID guideline in the primary healthcare setting in the scenario.
Hello, it's emergency line. Anna speaking.
Hello, Anna.
Yeah, what's happening?
Is Louise up a bit short wind?
Yeah. Okay, Louise, I'm going to come and see you. It's going to take me about 15 minutes. I want you to go and wait in the area where people with the virus are going. Before I see you, when I get to the clinic, I'm going to need to put on my gown and my gloves and my mask to protect me from the virus, okay? So I'll see you really soon.
I'm now going to don my PPE, starting with hand hygiene. I'm going to put on my gown, my mask, my goggles, and my gloves, following the donning poster. Hi, Louise. Hello. Like I'm not scaring you. Just got to put this mask on, okay? All right, come on through. All right, we're going to go get on the bed. You're not looking very well. Are you feeling okay? No? Okay. Louise, can you hear me? Louise? Louise? Batavia, I need some help. So Louise has become unresponsive. I'm now going to go through the DRS ABCD. So danger, my PPE is intact, I've had it spot checked, and family are waiting outside. Louise, can you hear me? Louise, can you hear me? She's still unresponsive. I'm now going to send for help. I'm going to call my driver for help. Mantavia, I need your help. I need you to get the resus trolley for me. I then need you to call the DMO through the switchboard and tell them it's urgent. And then I need you to put on your PPE following the poster that's on the window out there. I'm now going to check her airway. I'm going to support it and check for any blockages, but I'm not going to suction due to COVID precautions. I'm going to put on a non-rebreather mask in 15 litres. I'm also going to cover the airway with a bluey or a piece of clothing to stop any germs or spit or virus coming out and potentially infecting us. I'm now going to be checking Louise's breathing. I'm going to be doing look-only checking. We're not going to be listening and feeling. I can confirm that she is not breathing. So we are going to be starting compression only, CPR. We are not going to be bagging.
Anna, I've got my PPE on. Can you please check it is intact?
Yep, show me your hands. Yep, that looks good.
And I've got a DMO on the phone. It's on the loudspeaker.
Thank you. Mantago, I'm going to need you to take over compressions so I can attach the defibrillator pads.
Okay.
So our pads are in place. Continue compressions, Mantago, until I ask you to stop.
Yep.
I'm turning off the oxygen. Mantavia, stop compressions while we do a rhythm check. The AED is confirming a shock. So we're going to shock. Everyone stand clear. Don't touch anything. I'm going to shock now. The AED is telling us to recommence compressions. Mantavia, do that while I turn on the oxygen.
Right.
Mantavia, I want you to continue compressions. I'm going to insert an IV cannula and draw up some adrenaline.
Alright.
Okay, I've got the cannula in. The AED is prompting us to do another rhythm check. Continue compressions.
Yep.
I'm turning off the oxygen. Stop your compressions. We're analysing now. The AED is prompting us to give another shock. Everyone stand clear.
Yeah.
Shocking now. The AED is prompting us to continue compressions. Please start, Mantavia. I'm turning on the oxygen.
Hello, this is Caitlin Leon from DMO. Can you tell me what's happening there?
Hi Caitlin, it's Anna. We have a 30-year-old woman, suspected COVID case, who is arresting. We've had we're up to our second round of CPR. She's had 2 shockable rhythms and she's received 2 shocks.
Okay, do you have IV access?
I have got IV access, yes.
Great. Can you now prepare a milligram of adrenaline and administer that to the patient? I am going to get care flat on the phone and organise a retrieval for this patient.
Yes, I've got that drawn up already. Delivering
Okay.
it now. I've delivered 1 milligram of adrenaline.
So now continue CPR as per the algorithm while we wait for the retrieval team. Anna, do you feel confident in inserting an LMA into this patient?
Yes, I can do that.
Okay, go ahead then.
Okay, the LMA is in. I'm just going to attach the viral filter and attach the bag. I'm happy there's no obvious leak. The airway's secure, Caitlin.
Okay, that's great, well done. Can you now continue compressions at a rate of 100 to 120 per minute while delivering breaths via the bag at a rate of 10 per minute?
Yes, we'll do that. Mantavia, it's coming up for another rhythm check. Just continue compressions.
Okay.
Okay, stop compressions. I'm turning off the oxygen. We're analysing. The AED is suggesting no shock advised. I'm going to do a pulse check. Caitlin, I can confirm there's a pulse.
Okay, so we have return of spontaneous circulation for this patient. So we're now going to commence post-resuscitation care. Can you continue to support the airway and the breathing for the patient? And I can confirm we now have care flight on the way to retrieve the patient.
Thanks, Caitlin. We'll continue to do all of that. And then Tavia, once she's on the way, once care flight have got her, we're going to need to make sure we clean this room and clean all of our equipment according to our guidelines.